Welcome to today's personal protective equipment needs for COVID-19. We recognise the traditional custodians of the lands and seas on which we live and work, and we pay our respects for elders past and present. By the end of this webinar, participants will know how to safely use personal protective equipment for COVID-19, including within different scenarios. Also, know how to support testing for patients suspected to have COVID-19 and how to safely clean clinical spaces to help prevent COVID-19. Today's presenters are Ms. Kathy Dempsey from New South Wales Health's Clinical Excellence Commission. Kathy is an expert in infection prevention and control who is leading the COVID-19 infection prevention and control efforts for New South Wales Health. We are also joined by Laksmi Govindasamy from Aboriginal Health and Medical Research Council of New South Wales. And now, Dr. Laksmi will kick off the webinar. Thank you, Laksmi.
Hi everyone, I hope you can hear me okay. We'll just do a little bit of brief background on COVID-19 so that people have a good understanding of what this virus is and how it's transmitted. So COVID-19 is actually the name of the illness caused by a new coronavirus, which is from the coronavirus family. And viruses from this family can cause the common cold, but also more severe respiratory diseases like SARS, which is severe acute respiratory syndrome, and MERS, Middle East Respiratory Syndrome. This new virus was first reported in China in December 2019, late last year. And initially it was called 2019 nCoV, meaning novel coronavirus, as it was a new virus at that time. Since then, the virus has been officially renamed to be called SARS-CoV-2, and that reflects the fact that it's got a similar shape to the virus that causes SARS. The disease caused by the virus is called COVID-19, and you'll have noticed in most of the media reporting and in New South Wales Health's documents, we're mostly referring to COVID-19 for both. Technically, they're not quite interchangeable. It's a little bit like how HIV is the name of the virus and AIDS is the disease that is caused by HIV. But if you see those different terms being used in different spaces and areas, that's what that reflects. Throughout this presentation, we'll just be talking about COVID-19 because that's a little bit easier to say. So we'll move to the next slide. This is a map that's a couple of days old now, but if you look up the Johns Hopkins University website, they keep updating this in real time. And you can see from the red dots essentially spread all over the world that COVID-19 has really spread globally. So this map represents locations of confirmed cases, and reflecting this global spread, the WHO declared that COVID-19 represented a pandemic on the 11th of March this year. Over 80 countries are affected and that number continues to grow. And this creates a huge problem because with personal protective equipment, or PPE, there's a global supply shortage and huge demand internationally. We're all after the same items, and it makes it really difficult to make sure that we can ensure our supply. As of Tuesday this week, there were over 380,000 confirmed cases worldwide and 16,500 deaths at that time. And there continues to be quite significant rates of spread around the world. On the next slide, we're just going to have a little brief overview of the situation in New South Wales. So as at 8 o'clock on Monday, there were 818 confirmed cases in New South Wales, and that has continued to grow in that time. You'll appreciate we had to get our slides in a little bit earlier this week, and this is an evolving situation, and so those rates continue to rise. The New South Wales Health website has got up-to-date information on the latest numbers, and they also have a map that allows you to see which local health districts or local council areas have got high rates of confirmed cases. And at this point in time, they're largely in the metropolitan areas, so particularly in Sydney, but there are also some spread even to places up in northern New South Wales. So I guess in terms of the pattern of who is being affected, initially most of the cases were related to imported cases, so to speak, in that they were identified in people who had returned from travel overseas. And that continues to be the case. I believe the country from which people have returned with the highest number of cases is the United States. But increasingly, we're now seeing cases of local transmission. So this is where COVID-19 has spread between people in Australia and in New South Wales. And that can represent a transition as people are now potentially catching COVID-19 in the community here, as opposed to bringing it back with them from their travels overseas. And so this makes it really important that we try and slow the spread of coronavirus in our communities to try and minimise the impact on the health system of everybody becoming sick at the same time. If we go on to the next slide, we'll have a brief overview of the main symptoms. So as a respiratory illness, the dominant symptoms are things like fever, cough, difficulty breathing, muscle pain, and tiredness. These symptoms are really similar to a flu-like illness, and the fact of the matter is that at this stage, on a clinical basis, we really cannot tell them apart. And so the key issue is to support testing. So with a laboratory test, which is taken from a nose or throat sample, is the best way for us to identify the people who have confirmed COVID-19. Because it's a respiratory virus, you can see from the image on the next slide that, in fact, the transmission is predominantly people to people, and it's via respiratory droplets. So that's what's produced when you cough or sneeze. Those droplets can be transmitted to the people around you. They can also land on your hands and on items and then be spread through those items contacting other people. So essentially, after that initial exposure, people may not become unwell straight away. It can take a variable amount of time, and it seems as though the average period is about 6 days. So say, for example, someone coughs on you or someone sneezes on you and you're exposed to the virus, it'll usually take 6 days or so before that person starts to develop symptoms themselves. However, that period can be really broad. It can be between 2 days to 2 weeks. And so that's why you might have heard about some of the home isolation requirements being 2 weeks. It's to cover that period of time. I think the concerning thing is that some people may transmit the virus before they develop symptoms. There are reports of this internationally. And also some people may have quite mild illness, and so they may not realise that they're symptomatic and infectious. And so this is why a lot of the changes around social distancing, staying at home, keeping a safe distance from others, and coughing and sneezing safely are so important. It's to try and reduce the risk of transmission and spread between each other in the broader community, and particularly for healthcare workers. So if we just move on to the next slide, slide 14. Because there is no specific treatment, and because there is no vaccine for COVID-19, hand washing and other preventative measures are really vital, because these are the best tools that we have to limit spread between people, both in the community and in the healthcare setting. So the really basic but important measure of washing your hands 20 seconds with soap and water and then dried thoroughly, or with an alcohol-based sanitizer, are absolutely vital. Coughing and sneezing safely, as I mentioned, and also social distancing. So that means avoiding public spaces that need to be there, minimising the time that you spend with others outside your home, working from home if able. All of those broader community strategies are really important. Most important of all is, if you start to feel those symptoms, if you're a healthcare worker, it's really important to stay home if you're sick, because of the possibility of transmitting coronavirus or any other respiratory illness to your colleagues and other healthcare workers, and to your patients. So this applies to us as much as it does to the rest of the community. If your kids are unwell, they shouldn't be at school, and it's really important to keep a safe distance. On slide 15, we're going to talk about how we identify cases. So in New South Wales, the testing criteria has been changing and rapidly updating. Last week, I'm sure many of you will have seen that there's now an inclusion for testing for people who are Aboriginal and residing in remote and rural areas. And in fact, this can be broadened to Aboriginal people who may have come from remote and rural areas or are going to them, and to really facilitate testing amongst the Aboriginal community to ensure that we have early identification of a case affecting that community. So I think that's something that's really important to bear in mind for clients in your services, but also to support them accessing testing in mainstream services, whether that's a respiratory clinic or the local hospital emergency department. Testing is free for everybody, and in fact, very early on, New South Wales Health said that treatment and further management of coronavirus would also be free, because it's really important that we identify people with the illness, irrespective of their Medicare status, and so we really shouldn't have that as something that would hold people back from identifying whether they have the virus or not. Unfortunately, though, as I mentioned earlier, this is a global pandemic, and so there is a limited supply of test kits. And so this is why we don't test everyone. There's a risk stratified approach to testing, and so people who have risk factors, for example, they have travelled or have been in close contact with a confirmed case, are the people who are most likely to be positive. Likewise, we don't test people who don't have symptoms. We completely understand that because of limited personal protective equipment or other reasons, ACTRISs may not be in a position to offer testing on site. And in fact, we would be really keen to support you to refer those clients who require testing to services close to them, whether that's the local hospital or a feeder clinic or a respiratory clinic. As well as that, outpatient pathology collection centres may also be offering testing in your area. There's a list of the pathology collection centres on the New South Wales Health website, and on our HMRC website we've also got a link to them. And potentially a good solution might be to give people a pathology request form and have them go and collect the sample at one of those centres instead. I think we've got Kathy on the line, and so I might hand over to her to talk about some of the key infection prevention and control principles and measures, which is the real crux of today's presentation. Thanks.
Thanks, Laksmi. I'm just checking, and hopefully that everyone can hear me. If we move through the slides, we're looking at infection prevention and control principles. And so we're starting off with the importance of environmental cleaning. Now, obviously, whilst we have using a hospital grade and a TGA approved disinfectant, the important thing for environmental cleaning is cleaning with a detergent. Viruses can be sufficiently sort of inactivated by this method. If you're not sure about the grade of the disinfectant, then we recommend a bleach and making that up according to the manufacturer's instructions, or looking at disinfectants that will have virucidal properties, or they have existing claims against other human coronaviruses would be sufficient. Then we look at waste management, and the recommendations are around following the routine disposal. So it's no additional disposal for waste around management of COVID-19 specifically. It's around those items meeting the definition for clinical waste and then putting them into clinical waste. So if you have a lot of PPE that basically you've used but there's been no contamination, there's been no incident, no vomiting, blood spray, no masses amount of gross contamination, then those items can in fact go into general waste. There are some states, however, that may have taken a little bit of a different approach. But look at the national guidelines coming out of CDA and HPC, so the Australian Health Protection Principle Committee, it's basically normal general waste and clinical waste according to the existing definitions. Linen management, again, there is no additional requirement for linen management, so that's basically the same. Hand hygiene using alcohol-based hand rub or hand washing, and you can use hand washing with a neutral or an antimicrobial. Then on top of that, it's respiratory, so cough etiquette and respiratory hygiene. PPE, so personal protective equipment, is based on transmission-based precautions, and I think we'll go through that a little bit later. So then if we move through to for healthcare worker contact with patients, so standard precautions apply to all patients regardless of their perceived condition or perceived status, and that includes hand hygiene according to the 5 moments, and definitely with any patient with respiratory symptoms or respiratory infections. So patients should and staff should observe respiratory hygiene and cough etiquette. So, you know, if someone's in a practice or in an environment and they're symptomatic, so it's keeping a distance, as Laksmi's already said, or applying a mask if you have it to the symptomatic patient. So transmission-based precautions for patients with suspected or confirmed COVID-19. So what we know of the infection is that COVID-19 is spread through contact and droplet. And so that is, the precautions are applied based on that. So they are contact and droplet precautions. Now the airborne precautions or airborne related precautions are added only during those procedures that are conducted and considered to be aerosolized generating procedures. So what that means is that there's usually a procedure where there's a lot more sort of fluid, a lot more sort of saliva, sputum, so it gives rise to greater travel, if you like, to those droplets. So then in terms of when patients with COVID-19 symptoms arrive at the clinic, what they need to do, so if they should be identified as soon as possible by effective triage mechanisms, and so some areas are putting almost a concierge at the door or something to actually try and facilitate some of the triage, putting a surgical mask on anyone that's symptomatic in the first instance, be placed in a single room that doesn't necessarily connect with other areas. So it's about identifying in your workplace sort of what areas may be able to accommodate these requirements. If you need to transfer them outside the room, then they should wear a surgical mask during transfer and keep that mask on for the entire time. So if you look at contact and droplet precautions, and I think this is probably causing a lot of angst and a lot of confusion in the system. Contacts between healthcare staff and patients, the PPE that's safe and appropriate before entering the room. So a lot of these were developed around sort of direct patient contact and a lot of kind of interaction with patients. So if we break up the individual precautions, so a long-sleeved gown and your goggles are associated with contact. And so where it's anticipated that there will be contact with a lot of fluids. Hence why in some environments we're trying to look at not so much rationalising, but applying PPE based on the risk assessment. So if we've got gloves and gown as your contact component, then you've got a surgical mask and a face shield or goggles, or actually what's more appropriately called is safety glasses. And then obviously disposal non-sterile gloves. So they don't have to be sterile, and then it's important that you make sure that you do appropriate hand hygiene. So, and then of course you do have another level of P2N95 respirator mask, and you know that might be something that you'll put in place if, for example, you're doing contact with a sort of grossly symptomatic patient, or it might be if you're in a prolonged area for a prolonged period of time. But in most circumstances, in sort of clinic areas, it's not that the P2N95s are better. You know, the levels of surgical masks 1, 2 and 3 provide more than adequate protection against droplets. It then just depends on the situation scenario that you're in at the time. So if we look at situations for contact and droplet precautions, so close contact with patients who are suspected of COVID-19, so the assessment is that they meet the testing criteria. When you are collecting a nasopharyngeal sample from patients with mild to moderate illness would be where you would apply contact and droplets. So, and in some of those you could rationalise whether or not you need a gown or an apron, or whether or not you need any of those at all. So in some of our drive-through clinics that we've set up, because there's really no contact, the patient's not getting out of the car, there are some centres that have decided to put on absolutely full PPE, whereas if you look at the risk assessment, it's around contact with the hands, if they're sort of going into a car, the mask and protective eyewear. So in that scenario, you could safely sort of risk assess that the gown or apron may not be required. If you're doing a lot of things, then you may assess that in that circumstance an apron or a gown might be required. So when do you need to add airborne precautions? So if the patient has severe symptoms suggestive of pneumonia, and these are usually around those patients that end up in intensive care. And the reason we've done it around that kind of scenario is, in intensive care, they're usually, they're critically unwell. There's usually a lot more sort of invasive procedures around sort of fever, breathing difficulties. There's frequent, severe productive coughing episodes and a prolonged length of time that a staff member may be in that environment. So during aerosol generating procedures, so nebulized medications, which we would strongly advise against. However, if clinically you need to administer for whatever reason, and that is best practice, then there are processes around how you actually can manage those safely from a PPE perspective and some engineering controls. Intubation, non-invasive ventilation is another one, and obviously CPR. So again, whilst it might be in some sort of specialty practices, the advice is against using those. The advice may in fact be that in certain groups it's essential that you do these types of treatments, and if that's the case, then it's around the adequate PPE and the patient placement and those sorts of things. So then if we look at contact and airborne precautions, so in normal practices, the airborne precautions is really associated with the P2N95 mask. So you need to combine your other transmission-based precautions based on the way that COVID-19 is spread. So we would put on a long sleeve gown, P2N95 respirator mask, fit checking, and that should be done each and every time you put a mask on, and that's around just ensuring that you've got a seal. Now, depending on the design of the mask, there are a number of different designs that require a slightly different approach to fit checking, and again, I think that's confusing a lot of people. Again, the face shield or safety glasses. So we're not expecting the goggles that, that we put out for Ebola. It's the safety glasses. It's still looking around the droplet spread. Disposable non-sterile gloves when in contact with patient, and obviously hand hygiene. So then if we look at the slide 24, which is P2N95 mask fit check, and this is really what we're kind of trying to hone in that a well-fitted sort of level 3 mask for droplet precautions will give you a lot of protection, and in some cases maybe provide you with greater protection than a poorly fitted P2N95 mask. So there's a little bit of discussion around fit test versus fit checking. Fit checking is the most reliable real-time check that you've got to seal. And again, you just need to be mindful that different masks will fit a little bit differently. Some of the molded cup masks, may look like they have a gap, but in fact sort of seal a little bit more to the face. Now, in terms of facial hair, if you look at the standards that the respirator masks comply with in Australia, the requirement is that you are pretty much clean shaven. So if you do have beards, then obviously the fitting of the P2N95 masks are difficult to achieve. And, you know, in those circumstances, we would either recommend that those staff either shave or are not involved in aerosol generating procedures. And then we've sort of given you the importance of P2N95 mask fit check and giving you some examples in terms of how you would do that and how you would apply those things. So then if we go on to environmental cleaning for COVID-19, so the recommendation is cleaning and disinfection. It's important that we understand the first level of cleaning with the detergent. There are combined products that you can use that will combine a cleaning agent that has a surfactant that will facilitate removal of dirt and organic matter. Most hard surfaces can be adequately cleaned with warm water and a neutral detergent as per the manufacturer's instructions. So that's around making sure if you're mixing up any solutions that you mix them according to manufacturer's instructions, you store them according to manufacturer's instructions, you apply them based on those, and you also, you know, if there's any recommendations around contact time and things like that. And then obviously you do a disinfection process on top of that, or you get a solution that has a cleaning and disinfection combined process, which would be most efficient. The routine cleaning of floors with detergent and water is recommended. So, you know, the risk is not so much what's on the floor and things. So it's around those frequently touched surfaces. So using a disinfectant is a chemical agent that rapidly kills and activates most infectious agents. So we normally don't recommend them as general cleaning unless they're combined with a detergent. So sometimes people will ask us whether they can just throw like a disinfectant on a surface or something that's, you know, has ethanol, alcohol on it. And realistically, unless you clean those surfaces first, then the disinfectant actually isn't really doing the job that it needs to. So then if we look at environmental cleaning after an AGP, so the cleaning itself is the same. It's around, you know, cleaning sort of high sort of frequently touched environments, but given if you do an AGP in a specific environment, that cleaning may need to expand, you know, out to more of that immediate environment. It's also around people making sure they've got PPE on whilst they're cleaning that environment. The reason, you know, there is a focus on resting the room, it's around how long it takes for those aerosol generated droplets to kind of fall from being suspended in the air to a surface. Now, you know, a lot of this is based on some of the historical evidence and that around, you know, measles. There is a number of other articles and research coming up around how long those aerosol droplets may suspend. And I guess it does depend on air conditioning, whether or not you can open a window and those kinds of things. But if, for example, you allocate a room that is purely for AGPs, you know, and for symptomatic patients, then there are workarounds and models of care ensuring that the staff are well protected with P2N95 masks around how you manage those areas.
Yeah, Kathy, we might just maybe take some questions. One in particular that I know will come up from this sector is that we've had a lot of trouble getting adequate supplies of PPE, and so people are really conscious about using it appropriately, but also I think there'll be some questions around prolonged use and potentially even reuse. So maybe you might be able to answer that question, and then if people have other questions, feel free to type them through and we might just have a bit of a question and answer with you while we have you.
Yeah, sure. So if we kind of start out with reuse. Now, Look, currently, as per our normal stance for infection control, if something is labelled as like a single use, then we would have difficulty in recommending its reuse. So that is, you know, I take it off, I put it somewhere, and I put it on again. So reuse, I think, is very different to extended and prolonged use. And there's actually some guidance and support globally around looking at extended and prolonged use. So extended prolonged use might be, you know, I put a mask and eyewear on particularly because they are the key components that are designed or put in place to protect the staff member. Right, so they're there to protect the staff member solely, and so you could rationalise putting on mask and eyewear. And if you're in a busy clinic, if you're in the room and doing all of the screening, you can stay in the mask and the eyewear for prolonged use. And for a surgical mask, that could be up to around two hours. It may be a little longer, maybe a little shorter. It depends on how wet you kind of breathe and when it gets wet. So definitely if there's any exposure, so someone has a massive cough and, you know, hemoptysis, and it's on the front of your mask, and that would be a definite reason to change. Otherwise, you could stay in it for an extended, prolonged period of time. Gloves would definitely need to be changed in between each patient and each sort of occasion of service, and making sure that you wash your hands. The issue with the gown, we're still really exploring in terms of how we can extend or prolonged use, because obviously anyone that's used to our normal practices, you know, for contact precautions, we would use a gown, you know, do what we need to do with that patient. That episode ends, we take the gown off, wash our hands and move to the next patient. So the gown does, I guess, lend itself to the fact that it is meant to be not only protecting the staff member, but protecting the next patient for dropping off of fomites. However, in saying that, we are looking, there are some environments where in actual fact we're putting the gown on more so to protect the staff member, and looking at how we can rationalise and use like extended prolonged use for those. But the minute you take them off, they are discarded. The risk of contamination is increased when you hang them up, potentially contaminated, and use them. So you can look at extended prolonged use, but as soon as they're touched or as soon as they're removed, they are discarded. We are looking at a lot of options around stock and around supply. For me to say that you can re-sterilise something is very difficult, because the issue is around whether or not we can validate that. So if you've got reusable glasses, like reusable safety glasses, then yes, you can reuse those, you clean them. You know, you might want to provide a staff member with a pair for the day, and then they are responsible for cleaning in between, and then have some sort of centralised repository at the end of a day or a shift before you actually, you know, rotate them out. I think that sort of answers that.
I think that was whether any GP consultations should be reduced to 20 minutes.
Look, I guess, I mean, if you look at, it really depends on what PPE patients have on. So if a patient has a mask on and they are symptomatic, then, you know, realistically there's no exposure. So if someone came to me and said, oh, I was in contact with a COVID-19, I was in a room, the patient was coughing but they had a mask on, I would more than likely say in that incident that there's actually no exposure because the patient's had a mask on, right? But if I have a patient who I don't know until they're in the room, then I guess, you know, if we look at the definition that, you know, contact is face-to-face contact of sort of greater than like 15 minutes, then it's about that spatial separation. You know, can you separate, like rearrange so that the patient is sort of well and truly sort of 1.5 to 2 metres away, those sorts of things, to just reduce that amount of contact. You know, I guess reducing contacts to 15 minutes may be beneficial. If it was then a contact, it would be borderline. You know, I guess we'd have to look at those other scenarios. And then if you had a number of patients during the day, it would be cumulative anyway, if that makes sense.
And I guess speaking to reducing face-to-face contacts for GPs, we're also increasingly seeing the opening up of telehealth options. And I just want to flag that for our members, HMRC will be sharing some more information about those telehealth options with you soon. Kathy, there's another question here. Is a surgical mask enough for emergency dental treatment?
Yeah, look, good question. And the answer in short, there are a number of, sorry, was that surgical dental?
Exactly.
Yeah, so I think particularly with dental work, you can segregate into sort of non-aerosol generating procedures and aerosol generating procedures. And look, I think some of that work is still really being better understood. But certainly if I'm just doing normal surgery in a mouth, you know, you might be able to rationalise that it's not. But if I've got like an ultrasound cleaner and things that sprays a lot of water around, which kind of gives flight to a lot of, then that changes to an aerosol generating procedure. I know that ENT surgeons particularly are looking at the risk around that. Certainly any procedure where, you know, there's a lot of added fluid per se, or a lot of saliva and a lot of potential sputum that's generated, that does increase the risk. But a level 3, if we look at the levels of surgical masks, 1, 2 and 3, they are all suitable to protect you against droplets. They just have varying degrees of barrier. And it's based on the pressure that's applied to that barrier. And, you know, realistically, I can take a level 1 surgical mask and I can run a full force tap onto that mask for, you know, well over sort of 5 minutes longer, and there's still no strike through, right? So whilst we have some categories and some suggestive you know, scenarios where each would be worn, they are actually masks that provide quite good like fluid resistant protection.
That's really reassuring. I guess kind of related to this broader question around PPE, someone's typed in, do you think we should be wearing personal protective equipment for all patient contact? So even things like immunisations or depot injections?
Look, I think there's definitely some momentum picking up on this aspect, given that we do have a lot of, or like our community transmission seems to be increasing. And I guess, you know, from an infection control perspective, we would bring it back to standard precautions. And I think, again, what is possibly not well understood or well taken up is our standard precautions outside of COVID-19, is that if you are in you know, proximity of any patient that has any sort of respiratory symptoms, you know, including your chronic kind of coughing type patients, standard precautions do actually tell us that where there is a risk of you know, contact or you know, contamination through splashing, spraying of any bodily fluids, then we should put on appropriate protection. So, you know, I'm loath to say that, you know, it's at the time where we should put on a mask for everyone, because I think given the challenging times of trying to rationalise and there's also the ongoing result of waste and things like that. I think we're still in an era where we would recommend risk assessing, you know, trying to, I guess, group high risk patients together versus low risk patients of COVID-19, you know, staggering your clinics and things like that, and applying a risk assessment. So I'll hand back to you.
Kathy, I guess as part of that risk assessment, most of our member services are primary care facilities. And so taking the view of a local AMS, do you have any recommendations about how that risk assessment could take place? Is it like having an outdoor triage area? What kind of strategies would you recommend?
Yeah, I think a lot of sort of clinic areas and things are doing, as I said, sort of previous, like a concierge at the door, which is sort of like your like initial triage to kind of, and I think for those people, if they're, you know, patient facing, then it would make sense that they would possibly be in at least a mask and some protective eyewear. And I often say, I mean, look, you know, depending again on the risk, but like definitely at that area, it would be reasonable to say, you know, like they walk in the door, there's someone who's triaging in a mask with, you know, like obviously a cough etiquette station, some hand hygiene, and then, you know, a box of masks and going, you know, have you got a cough? Have you got a fever? Have you got a, you know, and if they go, I always have a cough, then I would be handing them a mask and then looking at where they fit in terms of, you know, the risk assessment based on COVID or based on any other acute respiratory illness. But it does really mean rethinking about our model. So rather than letting people come all the way into your service, before you work out, you know, who else they've passed and who else they may have coughed all over, you know, whether or not you can rearrange some of those types of kind of settings.
Thanks so much. I think that's a really great response. And I know that some of our services, with the assistance of their local health district infection control support and the support of others, have started implementing those strategies. And so I think, like you say, kind of rethinking having people come all the way inside and potentially exposing other people in the waiting room or other healthcare workers, it's a really important strategy to have that sort of concierge or initial assessment of their symptoms. So thank you so much, Kathy. I appreciate that we might need to let you and Andy go. I think we've got through all of the main questions, and so we might just proceed through the rest of our presentation. I'm very sorry, everyone. Oh, sorry, here's just one last question come through while we've got you, Kathy. The question is, should all patient contact be done outside?
I don't know that I would say that all patient contacts need to be done outside. I think it's really just obviously on entrance, there needs to be like a, you know, quick kind of triage, and then working obviously through your zones within what environment you're at. And sometimes that, you know, it helps to either engage someone that has some infection prevention and control experience to help you with that. You know, I have to say, I think our way of doing things post COVID-19 will just, you know, emulate all the things that from an infection control perspective we, you know, felt you were all doing or should have been doing, and will probably set us up in, you know, good stance moving forward. There are recommendations, for example, if you don't have a suitable environment and you really need someone to, you know, give you a great sputum, then that might be best done if you sort of give them a sputum and get them to go outside, you know, away from anybody else, and that reduces that aerosol generating procedure environment. Hopefully that kind of answers that question. Thanks, Laksmi.
Thanks so much, Kathy, and thank you again for your time. We know that you're very busy in the emergency response, so thank you. So Just to close, in the last little while, I just wanted to talk through how some of these infection prevention and control measures could be put into practice, and have a little think about a patient's journey to their local AMS. So in this example, we've got Granny Ellen, who feels she's coming down with something. Overnight, she's felt hot and sweaty, and then this morning she's got a bit of a dry cough. She's worried about her asthma, and so she decides she wants to go and get a checkup. And her granddaughter Eliza, who's feeling perfectly well, takes her grandma to the AMS. When they arrive at the AMS, they notice some signs, and so they follow the signs' instructions, and they're greeted to a triage area. And so in the triage area, they get asked about some of their symptoms, and they let the triage person know that Granny Ellen is there with some respiratory symptoms because she's got a cough and maybe some fever. So they're led to the hand station, and they're able to clean their hands. Granny Ellen puts on a surgical mask. Eliza doesn't because she doesn't have any symptoms, but they both clean their hands. And there's some good information sheets available on how to put on a surgical mask properly, so it's covered both the mouth and the nose. In the waiting area, the chairs are quite widely spaced out, and Eliza waits outside in that general waiting area, and Granny Ellen is led inside to a special isolation area for patients with respiratory symptoms. And in that isolation room, it's separated from the main area where other patients and other staff might be. And the aim is for patients in that room to be prioritised, so they're seen very quickly by the doctor to try and keep the time in the room and their time with the clinician as short as possible. We've got a bit of a question. Hopefully you'll be able to type in your answers. What does the general practitioner seeing Ellen need to do beforehand? There's a bit of a clue there in the photo. So definitely hand hygiene, contact and droplet precautions. So as Kathy mentioned earlier, that includes the long sleeve gown, a surgical mask, potentially a P2 mask, depending on the severity of symptoms. But in this instance, Granny Ellen's symptoms are quite mild. A face shield or safety glasses rather than goggles, and disposable non-sterile gloves. And of course, hand hygiene is the priority. So the GP does an assessment. They review Ellen in that dedicated treatment room for patients who have respiratory symptoms. They note that Ellen's symptoms are mild overall. She's got no shortness of breath. She doesn't have severe bouts of coughing. Her temperature is normal. She might have had some fevers overnight though. Based on her assessment at that time, Ellen doesn't meet the criteria for COVID-19 testing, but the GP is worried about other respiratory viruses given that Ellen lives with other health conditions, including diabetes and asthma. And so because of that, the GP collects a respiratory sample to send for a flu test. Because of the high suspicion of flu and the fact that Ellen has these risk factors for more severe illness, the GP decides to provide some oseltamivir or Tamiflu. And the GP plans to call Ellen with those results from the flu swab and provides advice on hand washing, safe coughing, and keeping some distance from family at home and staying away from community events until she's well. So after Ellen leaves, there's also some responsibilities. So it doesn't all end with patient care. And the key thing there is to undertake cleaning and disinfection of the clinical space, and routine cleaning and disinfection of the waiting areas, and particularly any high touch surfaces. After cleaning, the GP can safely remove the PPE and wash their hands. So the key message there is to always, always, always wash your hands. And we've got some great new resources, including this poster from the HMRC comms team that are available now on our website around hand hygiene and cough and sneezing safely. And there's also some really valuable resources, including from an infection control perspective on the CEC website. I can see here we've got another question coming through, and if Kathy is still on the line, the question is, if we're going to screen for influenza, so that therefore the patient has symptoms suggestive of influenza, why wouldn't we test for both if they also have COVID-19 screening?
So I am still online. So again, I mean, the advice is we would definitely recommend, you know, doing both panels. So, but I'm just not sure what the laboratory is putting out there. But, you know, I think the thing is, given we are coming into flu season, it's not impossible that patients could be co-infected. And definitely if you're screening for COVID, but they've got other signs, I mean, I'm not sure why you wouldn't do a respiratory panel as well.
So I think, and to add to that, I think in this example, it was created slightly before some of the recent changes to increase testing accessibility for Aboriginal patients who may not have other risk factors. And I think it would be quite reasonable to test for both if you're taking a sample and you have suggestive symptoms. I think as much as possible, we would really encourage testing according to the guidelines and as accessible. So supporting patients to access that testing through outpatient settings other than your own, as well as taking samples where you feel safe to do so. So finally here, I think we've just got a few more minutes for any other questions if they can come through. And I'd just like to acknowledge and thank the team at Redfern AMS who very kindly had me come and visit and observe their new triage systems in place and their new infection prevention and control systems in place. And so thank you to them for some of the photos in this presentation. And also I'd like to acknowledge Kylie Taylor and Christy Crooks from Hunter New England Local Health District who have helped with some of this presentation and particularly with some of the resources that AHMRC are developing.